today's World Insight, a tipping point of the COVID strain XBB, fueling fears of a new wave and reinfection. What are the hard, cold facts about the spread of coronavirus variants? And what will it take for a global approach to curbing them?
Hello, I'm Tian Wei, and welcome to World Insight. XBB is a new Omicron subvariant, which has become the dominant strain in some countries due to its increased transmissibility and ability to pierce immunity. In the US, for example, XBB 1.5 is estimated to account for more than 40% of COVID-19 cases in the week ending December 31st, according to the US CDC. In China, XBB has been detected in at least a few municipalities and provinces, but experts said it was found in imported cases placed under closed-loop management, which has not caused the local transmission. Could XBB and other subvariant of Omicron fuel another COVID wave? How much can we learn from one another in terms of COVID-19 prevention and control 3 years into the pandemic? I asked these questions to these experts. I'm glad to be joined on World Insight by Dr. Vinita Bao, who is an immunologist at the Indian Institute of Science, Education and Research in Pune, and Dr. Monica Gandhi, professor of medicine from the University of California in San Francisco, as well as Mr. Kerry Bauman, assistant professor from the University of Toronto's Faculty of Medicine. Ladies and gentlemen, what a pleasure to see you, and thank you so much for offering your insight on the program.
Thank you.
Happy to be here.
Let me start by asking you about what do we know now for the new variant XBB, some suggest as XBB 1.5. Professor Bauman, tell me more about your information.
XBB 1.5, it's actually different. You know, the two things are different. So I'm going to add the 1.5. It's certainly, you know, in the United States without question, and it's fairly significant in the United States as well. And it seems to be in different parts of the world. It's certainly in the United Kingdom. It comes from Omicron. People are watching it closely. It seems to be quite contagious. And certainly it's within Canada as well. That's the country that I am in presently.
Dr. Bao, from a developing country, also in Asia, how much do we know about XBB 1.5 and how much impact it is having on the population in your country, for example?
So it will be difficult for me to specifically talk about XBB 1.5, but XBB appeared, and as you know, as the time goes on, there are further subvariants of that. But XBB appeared and was reported in India from September 2022 onwards, and it is slowly going up. So I won't specifically be able to give numbers and proportions of the XBB subtypes because those I don't really remember. But there is a steady increase in XBB, and currently about 70% of the RT-PCR positive samples which have been sequenced in, say, in late December have been XBB. So in India, that is what we are seeing. The case numbers are not increasing. About 200, 300 per week is what is getting reported. It could be underreporting, but obviously, because people are doing testing at home with the self-testing kits, and that is not getting counted. But all one can say is that the hospitalization rates have not increased, which means whichever XBB variant that we are seeing is actually as good or probably better than the earlier Omicron, which was approximately 1 year ago. I must add a little caveat to this. The data are somewhat uneven between south part of the country, South India, and the northern part of the country. So XBB is more commonly reported from the south.
Now, we go to Dr. Gandhi. Since you're based in the US, we know there have been a lot of reporting about that and the rise of cases. What has been the impact now on the general population where you are?
The impact, like in India, has not been severe at all from XBB 1.5. Increase in cases, but not in hospitalizations or in severe disease. And that really is for two reasons. This is an offshoot of the BA2 Omicron subvariant, and essentially, like all the Omicron variants or subvariants, this is a less virulent strain or subvariant of SARS-CoV-2. So all of the Omicrons are in the same family, less likely to infect lungs, less likely to cause severe disease. Beyond that, we have high levels of immunity here in the United States. We have about a 78% vaccination rate in those 12 and older. We have a lot of natural immunity because there were so many waves of Omicron and its variants and subvariants that between probably January of 2022 and now, a lot of natural infection. Maybe 95% of people have either seen the virus or seen the vaccine, according to data from the CDC with spike antibodies last March. So that's how high of levels of immunity we have. So when you have that much immunity, the XBB 1.5 is not affecting us very much in terms of severe disease, will increase cases, mild disease, because it's more transmissible, but doesn't seem to be less virulent, doesn't actually evade the immune system. If you think of cellular immunity, T and B cells, probably evading antibodies though, which brings up our cases.
There have been some reporting in the media about different symptoms or obvious symptoms of XBB 1.5, for example, diarrhea-related kind of symptoms, and also some of the others. Now, how much worried are you about those symptoms, even though we have seen similar symptoms in earlier waves of Omicron and certainly of COVID? Dr. Gandhi, please.
So actually, all of the Omicron variants and subvariants seem to have more of those gastrointestinal symptoms. We saw that from the beginning of the Omicron wave. It was first described on November 26, 2021 from South Africa. And there's more of that GI symptoms, certainly respiratory symptoms as well, but it's more upper respiratory symptoms. So the runny nose, sore throat, and it doesn't concern me in the sense that that doesn't make it more infectious. I think what makes it more infectious is that it seems to bind more tightly in the receptor binding domain to our host cells.
We do not yet know the exact number as to date about the vaccination rate, but certainly vaccination of the most vulnerable group is crucial, as you suggested, Dr. Gandhi. Go to you, Dr. Bao, about the concerns of XBB 1.5. Now, one of the aspects is what have we learned over the past 3 years, and therefore better armed us with both knowledge, sophistication, as well as immunity, quote unquote, in the population. Now, in a country like India, which is population base can be compared to China as well, how much have you learned? And therefore, when it comes to a new wave like XBB 1.5, what does it mean to you?
It's a long course that one will have to draw and not necessarily extreme parallels with China, because when the Delta wave came up, which was in 2021, and it hit India very, very badly in May, June of 2021, at that time, the hospitalization rate was very high, oxygen requirement was very high, and the death rate was also very high. But remember, please, at that time, vaccination had started only for the health workers. And the other population as above 60 was slowly getting vaccinated. So in general, vaccination coverage was very, very poor at the time of Delta wave, which was, as I said, May, June of 2021. So it appeared that Delta was much more disastrous, much more infectious, much more problematic as compared to what we see with Omicron wave. Omicron wave came to India January 22. Yes, December 21, January 22 was the peak period. The actual infections probably were much higher, but hospitalization was much lower. So there could be two ways of interpreting it. One, Omicron was absolutely not as dangerous in terms of ability to infect as the Delta was. The alternative is, and both have pluses and minuses, that there was much higher proportion of the immunized population in India, so that despite differences in Delta and Omicron did not create as much of a disaster as the Delta wave created. And this is where I was trying to sort of speculate about China, that we had Delta wave, we had devastation and a lot of problem. Then vaccination picked up, in fact, post Delta wave, and Omicron was not so much of a disaster. Also, there was better preparation of the infrastructure. In China, because of the zero COVID policy, the Delta did not have any impact because it possibly did not reach the people.
We have seen economies open up at different times. For example, of course, some countries never closed, but also quite a high fatality rate at the very beginning, particularly of the earlier tsunamis of COVID. Other economies such as New Zealand, for example, Singapore, South Korea, they open their border at different timetables compared to quote unquote the West. So they also experienced the different timetables. Now for China, of course, it's also a different story. So one question is very crucial. I do want to ask you, Dr. Bao, about that, since you mentioned a very crucial factor, that is different countries have been handling COVID at different timetables. So how much of what others have been doing could be of reference for quote unquote ourselves?
Yeah, well, it is really a complex question. Really, multifactorial impact will be there. But what I see is right now it appears that there is widespread infection, at least in big cities. So once the big cities are have people, large number of people who are getting infected. In India, we had seen COVID spreading from big cities to relatively smaller cities to smaller cities and to further smaller cities and towns. So that kind of spread because people move back and forth. And initial input was partly from air travelers. So that's what I also see happening as a speculation, that suddenly if you see the peak and then there will be infection coming down. So that was very much the case certainly for Omicron, very sharp but a narrow peak of about 2 months. Delta was much wider.
According to some local health authorities in China, some of the mega cities have already peaked in terms of the latest rounds of Omicron. But of course, the nationwide will still have to see there are a lot of complicated factors, including the Spring Festival, which is the traditional Lunar Chinese New Year traffic rush. But this is a very crucial question. I think you, Dr. Bao, raised about what can we learn from one another and how much will that provide us with more awareness or possibilities for preparedness. Dr. Gandhi, I also want to go to you for that before I go to Dr. Bauman. Let's have Dr. Gandhi now.
You know, every country, like you said, did this differently. I will say that a Nature Medicine article showed us that the strongest predictor of how most countries did, and this was across Europe, the US, and Chile, were rates of vaccination in the elderly. And that is really 60 and above. That was almost the sole predictor of how countries did throughout this. And that was in the Western hemisphere. In terms of what was happening in India and China, India did not choose a COVID-0 approach. And unfortunately wasn't vaccinated enough, with a 4% vaccination rate by the time that Delta came. But after that, did really well with vaccination, and there was a lot of natural immunity. China has spared itself the earlier waves, but there are other consequences on public health to have such a lockdown approach, which is why finally the country sort of said no. It's time to open up. So I think we're going to have to go across countries and really compare them. I think about the US and Canada a lot as comparisons. They were some cities like which you'll go to next were more locked down. Ontario was more locked down, I think, possibly, than other cities, and San Francisco was more locked down than other cities. So even cities did it differently. But it really, what seemed to matter was vaccination rates in the older population.
Yeah, we all remember the challenging time when vaccination was such a debate, quote unquote, unfortunate debate, shall I put it that way?
Yeah.
Especially for scientists and medical workers like you, there's nothing to debate about really. But that was just the reality, shall we say, over the past 3 years since vaccination was available. Go to you, Dr. Bauman, same question. At this point, how much can countries learn from one another, given the different circumstances we are in?
Probably the most important element right now is data sharing. We really, really need to understand, you cannot attack a problem that you don't fully understand. And I'm not just speaking about China or Canada or India. I'm speaking about all countries in this world. Data sharing is critically important. When you look at, how Omicron originally surfaced in the Republic of South Africa, how quickly they were able to give that information. And that's very, very important. But, we're in such different realities. Canada has very high vaccination rates, even higher than the United States significantly. Our challenge right now is the public has mostly moved on and decided that Omicron is not really anything to worry about anymore. And, for many people, that may be their reality because they know people that have had it and they say it wasn't that bad. But for vulnerable populations, there's a lot to worry about, even in vaccinated populations. So that's a major consideration. And I think it's very important as well that we step back a little bit sometimes from the medicine and look to the messaging. Who are our vulnerable people? How can we share information? How do we do this? I actually think, the travel, not so much restrictions, but insisting that people be tested before they come from China to Canada or the US or Britain, I don't think is realistic. I mean, I think wastewater is a much better, way to look at that. And I think it's very important we don't make bad political decisions. When South Africa was forthcoming with that very important information, we slapped them with all kinds of travel restrictions and travel from Africa became very, very problematic for all kinds of people all over the world. So, there's all these different levels. There's the political, the social, and the epidemiological as well. So these are big challenges.
How do we see the most important factors, let's just put it this way, of public debates that we should have these days, rather than the public debates that we are having, or others told us that we are having?
I think fundamentally that we have had an erosion of trust in public health across the planet. And it's very evident here in the US. And I'm sure it's evident in China as well, because there are older people who are declining the vaccine and declining boosters of the vaccine. I think that polarization has resulted from the different policy choices that different countries made. People were very critical of Sweden at the beginning of the pandemic. Sweden ended up actually doing quite well in terms of excess deaths from other causes other than COVID. We are now seeing excess deaths in younger populations in the UK, in the US, in Canada from deferred medical care. So the way that I think of kind of COVID, and I actually wrote a book about this called Endemic, is that you cannot eradicate COVID. We knew that in April of 2020, the minute it was identified in animals. That was the first time it was identified in animals. There are many other reasons, but let's just stick with animal reservoirs why you cannot eradicate COVID-19. So in infectious disease epidemiology, you have to get to a place of control, and control means as low of severe disease as possible. And how to get low rates of severe disease, vaccination, and importantly, therapeutics for our vulnerable populations. That would be Paxlovid, molnupiravir. These are oral therapeutics for our older populations. And we don't have equity of those therapeutics worldwide. We don't have a complete acceptance of the vaccine or of therapeutics worldwide. And so we're not in a place that we have, worldwide control, but we're going to have to live with the idea that we're going to have to live with it is everyone sort of coming to terms with that in different nations at different times. And there have been other effects of public health, of closing schools, of closing other medical care, and we're going to have to balance all these. I call that a harm reduction approach. So this is where I think we need to be with COVID. No, you can't eradicate it. No, we have biomedical advances, and those biomedical advances have to be distributed equitably and taken up by populations.
Of course, we have seen COVID evolving over the past 3 years, different variants, and therefore there has been debates about the effectiveness of therapeutic treatment, sometimes coming from, the medicines for other specific diseases, but we are using it as an emergency. So how do you see the debates about that, and how much would that means for the confidence that the public can have in science, quote unquote science?
Hong Kong studied early lopinavir ritonavir, for example, as a treatment for COVID, which is an HIV drug. It didn't work. There was in vitro data that ivermectin and hydroxychloroquine would work, but in big clinical trials, they did not work, though they are still being administered sometimes in different places. Really, the only medications that seem to work in clinical trials are monoclonal antibodies, and they have lost their effectiveness with some of the variants. And so we really have to focus on the oral antivirals. And the two major oral antivirals that we have in this country is one is called molnupiravir, the other one is called Paxlovid, and they are not affected by variants, because the way they work is that they're upstream of the production of the virus. They actually stop the production of the virus, including the variants. So there will not be effectiveness changes yet with molnupiravir or with Paxlovid. They need to be more distributed equitably around the world. There has been, polarization around treatments, but we do need treatments with our vaccines to control the infection, because older people, even when vaccinated, can still be susceptible, and those treatments also prevent severe disease. So that's all I can say, is that we need both of them in every country.
Dr. Bao, about your thoughts, what should be actually we debate about these days, rather than what we are being fed about what the debates should be?
I think the debate needs to be informed, for which there has to be a certain level of understanding and information communicated to the people at large. So that is not something that happens necessarily in India. And I would slightly shift the focus and would say that public health infrastructure strengthening is something that is required. People do not understand that having access to easily affordable or at times free, especially for very poor people, healthcare system is essentially a basic requirement, because that if that is not demanded and if that is not obtained, then we are talking about really minority, 5 to 10% of the Indian population, which can easily afford private healthcare. And in that sense, Canada healthcare is an example, but a few other countries who are very good about providing public healthcare system to anybody and everybody in the country do certainly better off than having massive privatization of the healthcare, because that massive privatization is essentially completely about therapy rather than prevention. So even vaccination is not the mainstay of private healthcare. It is part and parcel of the public healthcare. So in that sense, I would say that India does not have good public healthcare system. There has been over the years shrinkage of government expenditure on the public healthcare system. And I thought we would learn a lesson because of the pandemic, which we probably haven't learned, though our budget will be out in another month or so, but at the same annual budget. But I don't think we have actually learned from what one reads in the newspaper. So making people aware that this is a requirement, because the economic disruption in the country was so bad that people simply could not reach anywhere and could get nothing, no treatment, no hospitalization, no nothing. And COVID wasn't that lethal. I mean, even in Delta wave, it wasn't that lethal like Lassa fever or other fevers are. So in that sense, we actually did this, we meaning country, whatever, did partly a disservice by not providing and not strengthening the healthcare system. And I think we need to demand that as information and probably as a right.
Very good point. Go to you, Dr. Bauman. What should be the public debates about, rather than what we are being fed it should be?
I mean, I actually think we have to learn to get along. I'm going to speak about global in a moment, but, in our country, we usually do get along, but, we became so adversarial related to vaccination. And look, I could not support vaccination more, but it's a question of how you do it. And we had a huge uprising. You might remember I was on this very show with you talking about it, which really hit the social fabric of our nation. I think we have to show respect. Watching the media today, I've seen criticism of China several times. And I think, with the wave of illness going through China right now, I think we should show some compassion for the challenges China's facing at the moment. And, I hoped, probably like you, Dr. Val, at the beginning of the pandemic, I hoped globally that, this would integrate us and pull us together and, nationally and globally. And I want to be optimistic. I think we've all learned a lot, but globally, it's been our greatest failure. I work globally. I was in Yemen in 2020, 21, and, the vaccination rate was 3%. I mean, there's such an inequality in terms of how we've done this. I think we have to think about larger strategies. This is not over, as Dr. Gandhi has told us, and we know, and I think there's more ahead of us. I don't know which way it's going. I can't predict, but I think global cooperation is going to be very important, and data sharing and accepting people's differences.
Great points. With that note, I have to wrap up our conversation. Time is very limited, but I have enormous amount of things I need to learn from you. I hope everyone in the world is also learning from the scientists and the medical workers like you are. Thank you so much for joining us and providing your insights on World Insight. And that's all the time we have for today. If you'd like to know more, search World Insight. Check out our YouTube channel. Follow us on Twitter and Facebook. I'm Tian Wei. On behalf of the team, thanks for being with us. Bye for now.